because thank you very much, Juan, and welcome everyone for the last session. And it's a well-known secret of conferences that you leave the best speakers for the last session so that people are motivated to come. So for the first session, we have Adrian Krenzer from the University of Würzburg, and he's going to be presenting on deep learning with extended vision for polyp detection. So Adrian, all yours.
Thank you so much. Thank you so much for the introduction. As you said, my name is Adrian. I'm here from the University of Würzburg, and I'm mostly my work is focused about gastroenterology. So I'm working together with the hospital in Würzburg, and we're mostly focused about polyp detection in real time. So we're trying to detect different diseases, but mainly polyps, while the intervention is going on. And yeah, today the talk will be about a user interface for automatic polyp detection based on deep learning with extended vision. And I will especially talk about this extended vision part as what we have done here. And also I would like to give a special thanks to the two engineers, Joel Toya and Boban Sutahiric, who were building the system. Like we are having one system, it was a classical endoscope, but it was like with additional cameras to the sides. And on this one, so that's the extended vision part about it. And yeah, I will tell you later more about it. So I also like to thank Michael Bank, who helped me with integrating the system and to actually do it for real-time application. So it's a colleague of mine at the Artificial Intelligence chair. And then also our supervisors, Christoph, Alexander, and Frank Puppe for all the supervision and the stuff they did with the animal trials that we had. But you will later on, I will talk more about it. So for the introduction, here you can see some examples of polyps, and they are already detected, as you can see. So when we're detecting a polyp, we're drawing a box around it to show to show it to the examiner, so that he knows that it is detected. And those images you see right here, they are coming from side cameras. So what we did is we had a classical endoscope, but we attached two micro cameras on there, like very, very tiny cameras, and they are going to the sides. So with polyps, it's like an extreme problem is that you can't really see everything in the colon because there are folds, there are different spaces which you can't really explore, which are hidden for the examiner. So he has to be very, very careful and actually check everything to actually get all the points about it. And so what we did there is we extended an endoscope with additional cameras. And those are examples from these side cameras. So they have lower resolution, but still you can kind of see the polyps on there. And then you have a detection. And then when you got the detection, then the endoscopist can go to the polyp and actually cut it out. And that's what it's mostly about. And to actually train our system, we used a lot of data for it. So we had like a big process of actually annotating. So this was like the main part also of my whole PhD was building pipelines that we could actually manage to really rapidly create a large data set to actually have enough data to build up an AI which really can work and in the end detects polyps in high quality. And we used open source data as much as it could get. So I was like getting all the data that I could get on the internet, and then additionally integrated with the data that we collected in Würzburg and in different centers around Germany. And so for the project that I'm presenting right now, the endoscope that we used there with the additional cameras, this was done in an animal trial setting because we had an approval for doing it in humans. So we had to do an additional data set, which was with animal data, and retrain the network. So we first trained it on the human data and then retrained it on the animal data to actually get it running then for the actually application. So, and you can see kind of the overview of the system right here. So just check, you have here the first part, this is the endoscope, and it has like the classical normal view. And the classical normal view is the one where the endoscopist would normally use. So that's what he's used to. And then there are two more, like going from the side cameras. And those are not shown to the endoscopist. So he will just see the classical normal view that he's seeing. And from there on, he can then later switch and see the other polyps that are detected by the AI system. So in the second step, we will go from the we will go from the side cameras to the AI system. And with the AI system, we will then trying to detect the polyps on the side cameras. And then in the last step down here, we have the user interface. And this user interface will then draw some small arrow like you can see here. Yeah, so the clinician is just seeing this one. And those are just for the AI. So the AI is detecting on the side cameras, so he doesn't get confused. I mean, you could scale this up and do it like with 8 or 10 or even more cameras all around the view. And yeah, I mean, already 2 more cameras would be kind of confusing for an endoscopist to actually do his examination. So yeah, it's kind of good to keep him in the same setting as he is before. So he's just the main camera and seeing everything on there. And then we have like a user interface which shows him, okay, now there's some detection on the right, there's some detection on the left. So he can just move his camera to the right side and then cut out the polyp. And yeah, that's what we did in this animal trial. So next, for the AI architecture, we used a YOLO-based architecture. So the original algorithm called you only look once. And what's most important about these algorithms is that they are very, very fast. So you can actually get quite good results while being very fast. And if you're doing real-time applications, you always have to be like very fast, because already minor changes in like the delay from the endoscope to actually the view that the endoscopist has, you already see differences, and he will know that there's a delay in there. Yeah, so this is the YOLO architecture, and it has like some kind of structure like a encoder-decoder network. So you have the analyzer, you have explicit and implicit knowledge, which is both learned with like different encoder architectures. And then afterwards you have a decoder and a discriminator, which will then in the end output the bounding boxes that were then used for the actual predictions. So for the whole system to work, we had like a whole video processing system. As you can see right here, this is the view of the classical endoscope. So we first had to grab the signal on the endoscope to actually get the original image, and also get this working and running through our system on the screen, so that it was everything was applicable. And then we have the 2 micro cameras which are on the sides. And those micro cameras, they are also grabbed with an Epiphone grabber. And from there on, we're then going to the AI and doing the predictions. And when the predictions are done, we're going on, and as you can see in the image before, we're then displaying the arrows to show where actually polyps are and where the endoscopist has to move and yeah, move forward with his stuff. So for the endoscope assembly, you can see right here we used 3D printing because you have to, like, these are very, very tiny cameras, so you have to be very careful with them. We broke like, I think, 3 of them during the process, so it was like pretty painful because we always had to reorder, and they were from China, so it was like always pretty long process to actually get them back, you know, and we were like extremely careful with those. And yeah, again, I like to thank the engineering team for doing all of that stuff, because it was very cumbersome. And yeah, they printed the this 3D cap, and then they had like those 2 holes here, which give it like a very stable and good fit, so that when you're moving the endoscope and when you're doing all the stuff. So the trial was in pigs, so it was like a kind of strange scenario too, because normally gastroenterologists don't work in pigs. So also the Alexander Meining, who was the professor doing the actual intervention in the end, he had to rely on a system which is like really good and was working while he was in this environment. So yeah, that's so we have those 2 holes, and then we have the setup which was 3D printed, and we got it all running so that those cameras are working. So, and here you can see some of the results again. So one kind of big problem with this approach is that you have to have like a lot of space on the sides, because mostly or sometimes it's like that the cameras are just too close to the mucosa, too close to the wall, and then you actually can see nothing. So you have a lot of blurred images and images that are not not that good. So you kind of had to deal with that and sort them out, or kind of disable the system right there. And then you have some other parts where there's enough air in in the colon, and then you can actually really see clear pictures like those, or kind of clear pictures in the resolution, and then actually polyps can be really detected in the system. And yeah, then you have the whole setup with giving the endoscopist the signal that he now can switch his camera, go to sites, and then really cut out the polyps. So to show you some results, we did some different analysis with different algorithms. As you said, as I said before, we are kind of using Yolo architectures mostly because they're quite fast and we have those real-time capability. And as you can see for the systems, mostly the precision and also the recall are not that good actually. So you could like improve them to around 90% or something, but still for like the low resolution and the camera sizing, and also the point that the cameras are mostly on walls and stuff, so it's way harder than to actually do polyp detection on the normal white view screen. It's kind of good. So additionally, you see here, for example, we could with the algorithm we used and trained, we could increase the F1 score by like 11 points and still keep it quite fast. So as you can see, the Yolo version 4 is faster than ours, but still we are like getting 10% in F1 score compared to this algorithm, and if we actually would apply this one. And down here you can see we had like 3 animal trials, 3 videos we used for testing in the end. So here they are split up so that you can see every single one of them. And yeah, sometimes some of the videos are more difficult because there are like more blurry images in there, or you have difficulties with actually being too much on the wall or different stuff which can happen, which in the end results in lower quality results. And so then we also use the FasterR CNN algorithm, which is like a totally classic algorithm. It's slower, but still it can achieve kind of good results. So I guess it's a good benchmark to actually see how results are going. And as you can see, it's eventually slower and also worse in the detection rate. So another thing I like to point out, so we had some difficulties with different detections, and as you can see right here, the first one, all of these, if you see here, these yellow stuff in the colon, this is actually feces, and it's normal that if there's too much feces in there, a gastroenterologist can actually do nothing, because you have to clean it, and in the end there's no way he can actually do a good colonoscopy if the colon is not clear. And this is the same with polyp detection tasks, because sometimes you have like things that kind of have the shape to some extent like polyps, and do also have like the size which is kind of the same, and then the system can detect those, and yeah, that's a problem. Additionally, we have bubbles. So when the examiner is like getting into it and doing like water or cleaning stuff, then sometimes there are bubbles that are appearing, and then those bubbles, they can get detected too by the system. And yeah, that's a problem too. And the last one is like light reflections, and we are trying on future work, we're like trying on really assessing those problems and to kind of deal with it. For example, you could lower the images a little bit, so that you don't have those hard light reflections that in the end give you these results. Okay, so this was my talk, so thank you very much.
Thank you very much. Any questions for Adrian? Yes. And the microphone, or no, because for the people who are virtual.
Yeah.
Hi there. As far as I understood, you're not really using the main endoscope camera, right?
Yes, exactly. So for the AI detection, we're not using it, but we had different projects before, whereas actually we're just about the main main thing happening. Yeah, but in this project, we just use the side camera.
Right, because I was thinking it might be useful to incorporate that as well in the detection. So trying to see how many polyps you detect using the 3 cameras at that point. Or I was wondering if you thought about using that at the validation stage, meaning how many polyps you would get just using the lateral ones as opposed to just the main endoscope, just to see how like effective this could be practically in the clinic, if that makes sense.
Yeah, exactly. So so we've done a little bit about that too. It's also written in the paper. So in the paper, we are like afterwards, as the whole examination we're done, we're then like really taking the widescreen classic image and doing detections and also annotations on that one. And then we have the side cameras too. And then we actually see how many polyps are missed by the front camera and how many are seen on the side cameras. So you're totally right. That's exactly what you should do. And I mean, in the end, when you apply this to a real setting in a real human, you would always use all the cameras you get, because why not, right? Yeah.
And then
Just a quick comment on that question. Usually during colonoscopy, the examination is done during retraction of the colonoscope. So the clinician carefully insert the colonoscope, and this skillful job to do it. And the examination is not done during that process. This examination is done during retraction. And having side cameras is useful because it actually tells the clinicians what is expected to be seen in the main view. So using only side cameras is actually does have a clinical value in it, right?
Yes.
Because it is prediction what would be in the main view.
Yes, exactly. Yeah, and I can also imagine like having kind of a 3D view in the future or something like this, so that you are actually really looking back, and then you have like everything incorporated and you get the most out of it when you have the whole view, and still not confusing the endoscopist with too many cameras, too many stuff going on. Yeah, so you're right.
Thank you for the talk. Just a really quick question. What is the unit that you measured the speed in?
The unit, okay, yeah. So let me just get back here.
So like iterations per second?
Oh no, this is like frames per second.
Right. Okay. Like so inferences.
Yeah.
Kind of.
Yeah.
So if you have,
I should make a quick note there, but it's in the paper it is written. But I'm sorry for that. You're right. So it's measured in FPS right here.
Right. Okay. So but then 39 is really good, right? You could maybe like make it a bit fancier with maybe even another camera or something. Because if you get to like 25 to 30, that's good enough, isn't it?
Yeah, I think so. For FPS, you have like 34 is already real-time compatible with 25 frames per second. So roughly. So yeah, then you're fast enough. And the endoscopist, so from my perspective, and when I talk to gastroenterologists, they're saying, okay, that's the threshold where they're actually saying, okay, I don't really see any delay happening. So that's what they really want. Yeah.
All right. Thank you.
So a very quick one. Thank you very much for the excellent work. So the problem of bubbles, so it's more a curiosity question. Did you already try hard to include them in a training? Because it doesn't seem that, I mean, your results are already excellent, and it looks like it's not the most difficult part.
Yeah, you're right. Yeah,
so the feces and the bubbles.
Yeah, you're right. So you mean, I think the same. So from a texture, they're actually not that different. So they're very different from the texture. So actually it should be kind of easy, but still sometimes, so I mean, in those images, I think also that it's kind of okay. But if you see, for example, the one down there, so I mean, here you see the bubble, okay, it's clear bubble, yeah. But this one down here, oh, I'm not sure if actually gastroenterologists could really know that it's no polyp, and he didn't have to check and go there and just see for it. So sometimes it's easy, but in other times, because of the view and also yeah, because of the angle of the camera and stuff, it's not that easy. So I'm not sure about it, but yeah.
Just a final comment. I don't know if you have considered changing the wavelength of the illumination, because if you go to infrared or others, then you can see oxygenation and other things, and then you can say that's a bubble or that is a vessel or something different. So especially with big polyps, then you would have vessels inside and all the time.
Yeah, I think that's very interesting too, and maybe we should really incorporate it. The thing is that about real-time detection, you always have to be like very you don't have to go with as much data as you can, because you really have just a minimum amount of time to actually do the prediction. So when you incorporate extra images with infrared or extra stuff which is happening, like for example depth estimation or stuff like this, it will always go computationally heavier, and then it's harder to so you kind of have to play with the best thing you can get, but still not take everything of it, you know. That's kind of the thing.
It's more for the clinical practice. So if this is a very good idea, they were mentioning that you have more cameras, and what they do is that they move it and then they change the wavelength. And
Yeah.
and you
Okay.
can do it on the spot.
Okay.
So you see something different at that moment.
Okay. And then you're just having this image incorporated. Yeah. Okay. No, I see. Yeah. Okay. Yeah, I can imagine.
Okay. So let's thank Adrian again. Next speaker is Laura Busto. We'll be talking about coronary X-ray angiograms. So something that Alex Frangi was talking about yesterday. So
yeah. Oof. Well, okay, first of all, I want to congratulate and thank all the people involved in the organization of this conference, and also thank you for allowing me to speak here. I'm Laura Busto. I come from Galicia Sur Health Research Institute in Spain. Well, I'm going to talk about how we are dealing with quantitative coronary analysis. Well, first, an outline of the presentation. But in first place, I want to introduce you the topic and the medical context, and then state the objectives of this work, following with the methodology we are proposing and the results we have so far, and then finally draw some conclusions and explain how we plan to continue the work. Okay, so coronary artery disease is a major cause of mortality in worldwide. The main symptoms include chest pain, fatigue, shortness of breath, or even the heart attack. And they are caused by the obstruction of the coronary arteries, which are the vessels providing the heart with the blood and nutrients and oxygen it needs to work properly. So this obstruction is mostly made by the buildup of plaque in the vessel walls that make narrowed parts in the artery that don't allow the normal flow of blood. And even it can completely block the vessel and producing the heart attack. So frequent medical procedure to treat this is percutaneous coronary intervention, which consists in implanting a stent in the narrowed part of the artery to open it. The stent is introduced using a catheter, and it is delivered to the desired location, guided with coronary angiography, having injected previously a contrast agent to allow the visualization of the vessels. And even though this procedure is critical in many cases for the patient survival, or at least it improves or relieves the symptoms, but there are many cases that do not take any advantage of using this stent. So previously, it's very important to assess the severity of the lesion to decide whether to treat it or not. Regarding the approaches to assess this level of obstruction, there are different ones. The most conventional one would be the visual analysis of the images, but it's very frequent, and it's accurate in the most severe cases, but it's not as much when the lesions are moderate, and it's certainly subjective and operator dependent. Another approach would be pressure-wide studies, which are accurate, and they are measuring the pressure differences across the lesion, but they are invasive, and then they imply more risk and more resources. They are in general more, the cost is higher. So the final approach, and the one we are focused on, are quantitative coronary analysis, which offer quantitative and objective measurements based on the images in a totally non-invasive way, based on the patient anatomy. So the procedure of QCA implies these steps. The first one will be film at least 2 orthogonal projections of the lesion, which need to be matched, and then select the most severe appearance plane, because that's the one which is determining the severity of the lesion, and identify the lesion length. This is where it starts and where it ends. Then we need to measure the artery diameter along this narrowed part and estimate how it should be in case of a healthy or non-stenotic coronary. And then compute the percentage of stenosis based on this reference. So our final aim would be to completely automate this procedure, but well, we are not there yet. We are still developing some tools to at least automate part of it. Okay, so this is the methodology we proposed. The first step would be, after acquiring the images, segment the coronary tree. We have trained a unit model with this purpose, but we didn't have the labels for the training set, so we made it using an annotation pipeline that we constructed, and I will describe later. Then as we only can use the contrast frames to perform QCA, we classify the frames into contrast and non-contrast ones using these model predictions. And then in the contrast ones, we determine the region of interest where the lesion is completely contained and analyze such region. Okay, regarding the images we are using, we have a data set of the images are belonging to 5 patients, which are from Álvaro Cunqueiro Hospital, the place I'm working. Okay. Of course, having signed consent, and we have 2 orthogonal projections filmed for each of them, making a total of 999 images. The images have been acquired using conventional fluoroscopy and SIM at 15 and 25 frames per second. They are 512 by 512 pixels and a pixel resolution of 8 bits. So for the dataset annotation, we have this pipeline, which consists in 5 steps. The previous one is devoted to noise reduction. We use medium filter, and then we detect the edges of the coronary vessels using fractal filter. Then there's a binary step, applying a threshold, and we remove the small objects. And finally, we included a minimal manual curation of the frames, which mainly consists in continuing uncontinuous threads and removing some speckles using GIMP software. So after having labeled the training set, we trained the unit. We used cross entropy as the cost function and optimized it with Adam Optimizer in batches of 2 images with a learning rate of 10 to the -4. And trained it for 120 epochs using data augmentation. And the model has been trained using NVIDIA GPUs. Yeah. So the idea behind the contrast classification is quite simple and trivial. It consists in using the number of foreground pixels in the predictions to determine if a frame has contrast or not. And then we proceed to the lesion identification in the contrast frames. We are now currently doing it manually by experts, and they determine the region of interest. For instance, in this image, the result, that would be the narrowed part the cardiologist has found. And then we analyze such region. The first step would be the extraction of the center line, which is performed by making a skeletonization of the binary image. Then the bifurcation are removed, and the borders are detected. As these curves were found pixel-wise, we interpolated and made it vectorized to gain some resolution. Yeah. And once we have this, we need to determine the orthogonal planes along the lesion. And these are the orthogonal directions are estimated using the neighboring pixels in the line, and then compute the intersections to get the segment size. And then what we claim is that analyzing this and performing this same method in the orthogonal projection, we can reconstruct the vessel and compute the percentage of, estimate the healthy coronary and compute the percentage of stenosis. So the results we have so far for this segmentation, due to time limitations, we only have a test set of 20 angiograms. They are delineated by the expert cardiologists, and they have been randomly selected from the contrast frames. We get the metric results we have in the table. And regarding the contrast classification, we try it with 989 frames, and as we can see in the histogram, which is a histogram of the number of pixels in the frames, in the predictions by the unit. Sorry, we can see two clearly different groups, and the next to 0 will be the non-contrast, and the others the ones with contrast. So, setting a threshold in 1,300 pixels, we are getting correctly classified 100% of the non-contrast frame and 95% of the contrast ones. Well, after having computed the orthogonal planes, we can make this kind of graphs to see the evolution of the vessel width along the vessel. And this would be what we need to do in the matched projection. Well, so the conclusions, well, these techniques can be used for the automation of the QCA, but if performed in the orthogonal planes, and they could improve the clinical practice. Well, of course, this is our first work in this line, so there is much work to do, and there is also room for improvement in what we already have done. But what we want to do is build a bigger data set to gain robustness, and something I find really important is make it easier for the practitioners to get the best plane to assess the severity, because well, this is key for the procedure to success. And then we want to automate the matching process and the identification of the lesion. And yeah, then finally, we want to validate this method using another approach to see if it works. And that's it for me. Thank you.
Questions for Laura? Mohammed.
Thank you very much. Just to clarify one thing, you mentioned you need bigger data set. Definitely, you need bigger data set than that. But you mentioned that the data is 5 patients.
Yes, of course.
And it's approximately just below 1,000 frame, or is it fluoroscopy, right?
What?
It's about less than 1,000 2D frames.
Frames, yes.
You said it's 8 bits image.
8-bit resolution.
Yes, but then later on you said you have the threshold where you take it at 1300. How is that an 8-bit?
Yeah, I think I maybe have a problem there. Yeah. Yeah, it would be 13,000, I think. Yeah, I think I missed a 0. What was it? So the images are 512.
So what's the 1,300?
What is there?
What's the number 1,300? This is the
Yeah,
number that you took to separate contrast.
I think I have a mistake. It's 13,000. And that would be the threshold for the foreground pixels in the predictions.
Okay.
Yeah, it's a mistake.
And when you separated the training and testing data or images, did you do it per patient or per frames?
No, we separated the patients. We guarantee that the patients are not used in testing.
Okay, so
Yeah.
it's per patient. Thank you.
Thank you.
Other questions? I have a question. So you do a final manual correction. So you do several steps and then you correct manually.
Just for getting the training set. This is meant just, I mean, we have to do it once for training the unit, but then we wouldn't need to do it.
How
Yeah.
easy would be, instead of having to do several steps and then correct manually, to do it manually from the beginning?
Well, I think it gains much time. I mean, the corrections are minimal. And in case of manually depicting, we had to do it to generate the gold standard to compute the metrics, and it takes much more time.
And on the same point, you are in the end, you're only in the occlusion part. So whether you have the reduction, so you don't have to do the whole branching. So why don't you just focus on that part and not on, because that's again manually delineated by the expert.
Yeah.
And then you just focus on that. So you don't
the
vascular tree.
Yeah, but yeah, it's true. But as we plan to in the future find the lesion automatically.
Okay.
Yeah, that's why we didn't spend that time. Yeah.
Let me check that there are no questions on the chat. No. Any further questions for Laura? Okay, thank you very much.
Thank you.
And we move to the last but not least speaker, Edward, who's going to talk about FCN transformers. You're connecting with your laptop. Okay. Remember.
Excellent. Okay, so well, thank you very much for the introduction and for inviting me to present our work. And of course, it's been an excellent experience, this conference, so thank you for everything that's gone into the organization of it. So I'm presenting our paper, FCN Transformer Feature Fusion for Polyp Segmentation. So we have another polyp segmentation method, also closely related to detection, but there is some interesting novelty here, which hopefully I find interesting and hopefully hope you will too. So just to quickly run through our clinical motivation, essentially colorectal cancer is a very deadly disease. It generally develops from polyps, and we generally use colonoscopy for screening the colon for polyps as it can facilitate detection and treatment, i.e. removal of polyps. However, that's all great, but currently, current colonoscopy practices, we are missing about 17 to 28% of polyps when we're performing colonoscopy, and any one of those polyps can become a cancerous tumor, and so it's really important that we reduce that. And yeah, it's a very concerning statistic. It has, however, been estimated on a more optimistic note that if we can improve these detection rates by roughly 1%, then we can reduce the risk of colorectal cancer by approximately 3%. Now, in addition to the detection of polyps, once we have detected a polyp, we also want to know whether it needs to be removed. And so that requires classification. And that is also due to varying morphology of polyps, a challenging problem that's also clearly important. And both detection and classification can be facilitated by robust segmentation tools. And so for that reason, we are interested in polyp segmentation. Now, just to go through our technical background. Now, of course, I think this conference is evidence of this. There is already a wide range of existing deep learning-based solutions for semantic segmentation. Yeah, I'm really quite interested in neural network design. And one thing I notice is that the vast majority of these methods fall into either the categories of fully convolutional networks or these newer transformer or pure self-attention based models. Now, what we've seen recently is that the transformer-based architectures have generally led to better performance than earlier FCN-based methods, particularly in generalizability, where we, by generalizability, I mean we train on one distribution of images and then test the method on a distribution of images which we assume to be somewhat different on the base. And the relevance of this is that these methods will likely be used with hardware that might not have been used during the collection of the training data. And so its generalizability is a key factor here. Now, this point's actually quite interesting considering some of the presentations we've had. So one thing I've observed from most of these transformer-based models is they typically perform coarse prediction, i.e. The segmentation map that they output has reduced size spatial dimensions. Now, of course, there was a talk yesterday on segmentation of, it was on coarse segmentation, and as well the Polyps 2-seg model also performed coarse segmentation. And yeah, we just, in this case, we assume that there is some benefit to pixel-wise segmentation. And so for that reason, point to this as a potential limitation. There may be some downstream tasks that require pixel-wise segmentation. Now, in addition to these two different types of architectures, we have also seen some hybrids, some attempts at combining them. But however, from the papers I've observed, they typically do not outperform the highest performing pure transformers and fully convolutional networks. So the main contributions of this work include the introduction of a simple yet effective approach for combining FCNs and transformers in a single architecture for full-size dense prediction, which, in contrast to the previous work I just mentioned, demonstrates advantages over these individual model types through state-of-the-art performance in Polyps segmentation. We also, the architecture that we have developed is really a modification of and extension of a recent model called SS-Former, which has performed really well. And so essentially we, this point is really on the modifications we've made to SS-Former, which I'll detail shortly. And so, yeah, and we also show through our experiments that those modifications lead to a benefit. So, yeah, so this is the architecture at a relatively high level. So just to run through, or to start with, you can see the image coming in at the top and the segmentation map predicted by the method at the bottom. Now, to run it through the main components, we essentially have these, you can, first of all, start by saying, you can see that at the beginning, the image gets taken in two paths, two parallel branches, if you will, and you have these two blocks which do not communicate with each other. There is no interaction. They just run completely in parallel. And so the first one of those is this transformer branch, which the design of this transformer branch was made so that it would extract the main shape of a polyp and essentially do the heavy lifting of the method. But due to the coarse representation that it outputs, which you can see the output of the output is of a reduced spatial dimensions, it's not necessarily going to be great features for drawing a good reliable boundary. Now we then have this fully convolutional branch, which is really designed to extract high frequency features, so edges of instruments, edges of the polyp, edges of the camera view, that then assist with taking this general shape that's extracted by the transformer branch to a quality segmentation map. Then, so that we can fuse this information, we first have to upsample the transformer branch output so that we can concatenate it channel-wise, and this is what I'm referring to as the simple approach for combining the strength of these methods. And then we finally process it with a prediction head, which is essentially just a fully convolutional network to fuse the features output by these two parallel branches. So to go into it a little lower level, so to start off with, we have the transformer branch. And as I say, this is based on SS-Former, and I'll be more specific on the distinctions in a moment. But you can see that this model starts off with you can see the arrow coming in from the top left, and you can see it comes down through this transformer. And in this case, we use the PVT V2, similar to Polyp 2 seg, interestingly. And so, yeah, we have that as our encoder for the transformer branch. We then have these local emphasis modules, which take each level of the pyramid and emphasize local features prior to fusion through the stepwise feature aggregation model of the features extracted from each level of the pyramid. We then have the fully convolutional branch, which is really inspired by recent fully convolutional networks for dense prediction. And this uses these very dense UNet style skip connections, as well as these residual blocks. And this was actually largely inspired by, for those who are familiar with these denoising probabilistic diffusion models. And so this is really uses a lot of similar principles as what's being used there, and those methods are being used to generate images with very high quality, high fidelity, and high frequency features. So yeah, that was the reasoning behind the design of the fully convolutional branch. And then we have the prediction head, which is just a couple of residual blocks before a 1x1 convolution with a sigmoid activation. So to draw the distinctions between FCB former and SS former, we first of all have the same image encoder. It's the purpose of the reason behind using the pyramid vision transformer is it's designed to be a robust encoder for dense prediction, and so it's very suitable for this task. And so we stick with that. We then modify the local emphasis modules. So you can see the local emphasis modules are still in the same place with the orange box, but with the blue blocks, we can see that we've used these residual blocks, which allow for a bit more complexity in the processing of features than what was used in SS former, where it's just convolution, ReLU, convolution, ReLU. And then there is finally the stepwise feature aggregation module, where we're again just increasing the complexity of the model using residual blocks as opposed to just single linear layers. And we do show the benefit of those modifications through our experiments. So the data sets we considered for these two experiments were the Cavasir seg and CBC Clinic DB data sets. These are just two popular open data sets for polyp segmentation, which contain polyps of varying morphology. We've seen these used in some of the previous presentations. And so yeah, onto our experiments. So you can see at the top we start with these two data sets. And obviously we do the usual splitting into training, validation, and testing sets. And we start off with a primary evaluation where we take the training and validation set from one data set and use that to optimize the weights of the model, and then test it on images from the test set from the same data set. And then we also have a generalizability tests where we are taking the training and validation set from one data set and the testing data set from the other data set, so that we can test this slightly out of distribution, slightly different distribution of images and see how it performs in that case. We also perform an ablation study of the FCB former, where we essentially built two extra models. The first model is essentially SS former, as I just showed you. The only difference between what we use and SS former is that we upsample the course prediction to full size so that it's comparable. Then we also have the same model, but with the prediction. We also start with SS former, remove the prediction layer. Then we add in the fully convolutional branch that we have with FCB former and the prediction head. So the key thing is that if we compare these two models, we can see the benefit of the fully convolutional branch and the prediction head. Yet if we then compare the results of these models to those for FCB former, we then see the benefit of the modifications to the transformer branch. So to jump into our results, so We tested a range of baselines alongside our model where we trained these models ourselves and using the respective code bases. And then we use the typical set of metrics for segmentation performance. And across the board, in all metrics on both data sets in our primary evaluation, FCB performer outperformed the baselines. So some examples from that primary evaluation. So these are some examples from the Cavassi SEG dataset where I've selected this was not randomly selected. I selected these based on, I was looking for challenging examples and noticed that there was where I would say that a challenging example is one that the baselines seem to struggle with, and notice that it's in these cases, the FCB former really allows us to get a good representation of the target. Now onto the generalizability tests. Again, we see a significant improvement in performance with FCB former, with the majority of metrics on both cases of the generalizability test, leading to better performance than the baselines. And then finally, on the ablation study, interestingly, there was one case where when we trained on Cavassi in the generalizability test, when we trained on Cavassi SEG and tested on CBC, the method without the modifications to the transformer branch led to led to worse performance actually. But in the three other cases where we tested this, FCB former performed better than the variance of the method, and so that's the majority of cases. So finally, I just thought it's quite nice to visualize this method and see what these components are doing. So essentially, we have of course, we have the input and the target in the first two columns. Then we have the average feature map of the output of the transformer branch in the third column, and then we have the average feature map of the output of the fully convolutional branch. And just to look at those two columns for a moment, you can see that the output of the transformer branch seems to already do, as was hypothesized, the transformer branch is able to extract the main shape of the polyp. We then have the fully convolutional branch, and we can see that there are highlights of edges, and these are essentially the edges that we believe that the fully convolutional branch has learnt will be important to represent when moving to the segmentation map. So the final two columns, we have the method in the first column with the as it has been proposed, and then in the final column we actually set the features output by the fully convolutional branch to 0, so that we have essentially turned off the features and turned off the fully convolutional branch to see how it benefits the final prediction. And we can see that there are certain boundaries which when we don't have the fully convolutional branch, there's kind of an overflow of positives, if you will, and the boundary is not well represented, whereas it's much better represented when we have the fully convolutional branch. So just to conclude, we propose FCB former, a novel architecture for dense prediction designed to combine the strengths of transformers and convolutional networks. We showed that this architecture achieves state-of-the-art performance in polyp segmentation and highlighted its particular strengths in generalizability and in segmenting polyps challenging morphology. And then finally, on this last point, as I say, I'm interested in neural network design and how these different methods are distinct and whether there are fundamental distinctions between them and how they should be combined. And I think the fact that was a simple approach to the fusion of features is an indication that there's more work to be done there. And I'd like to work more on that problem. So finally, to acknowledge our funder, STFC, and also the kind people at CSD3 and Dirac for allowing us discretionary time on their amazing compute resources. And finally, thank you all for listening.
Thank you. Thank you. Questions for Edward? Yes? Hi. Wait a second. For the benefit of the people who are online.
Thanks for the great talk. I really appreciate it. You showed a lot of details of your architecture. And also I have one question regarding your architecture.
Yeah.
Maybe I haven't seen it, but is the transformer branch using a positional encoding or is it not using a positional
So
encoding?
the pyramid vision transformer actually does not have a position encoding. The pyramid vision transformer does. The pyramid vision transformer V2, which we are using here, uses a convolution, an overlapping convolution to implicitly represent the position.
Okay, so the convolution makes sure that kind of the transformer learns to adhere to the kind of structure.
Yeah, I mean, I believe the reasoning of behind that model is that the overlap of the convolution of the patches essentially means that there will be the same features in multiple patches that allows the transformer to realize what patches are close to each other, if you will.
Okay, thanks.
No problem.
Other questions? I have one, and it's more about the training. So when you show the results of the unit, the challenging ones,
yes,
it seemed that the unit was not learning. So what was your training data?
Oh,
That's the other way.
The other way, isn't it?
Because unit, it is that one.
So just to be clear, these examples were chosen on the basis that the baselines struggle and essentially across the board we could see especially for the last three the three models represented on the last three columns. Our method performed almost across the board better, but I did find that there was this interesting pattern that there was some significant failures of those last three models where our method and PRANet and sometimes MSRFnet also performed quite well.
Yeah, but it's surprising because when unit doesn't perform well, it's because the training data was not sufficient or was not cropped. So if you see the top one, that is the best one, it's following down the shape that you have of the polyp and is missing the last part on the top. But the middle one is like really, really bad.
Yes.
So
yeah.
So the question is more about the training data. Was it?
I mean, so so the training data is as we is just the we do a 80-10-10 split and use 80% of the data for each data set for training the model corresponding to that data set. I believe
you use patches and different sizes of patches and different strides and other things
in UNet. Sorry,
for the training. Yeah.
No, I use the code base as it was as it is on GitHub essentially.
Okay. Any further questions for Edward? Because we're a bit tired. Okay, let's thank Edward and the three speakers of this session.